Good afternoon, everyone. I'm Cleo, and I'm going to spend the next 7 minutes summarizing the findings from our scoping review. Poor mental health disproportionately affects people from minority ethnic groups in the UK. The research for this is complex, and it varies both within and among different groups. But the research does indicate that there is an association of having a higher risk of mental illness and having worse treatment and mental health outcomes associated with societal, structural, and institutional factors, such as racism and discrimination, social and economic inequalities, and mental health stigma. Emerging evidence related to COVID-19 has also suggested that there is an adverse impact on public mental health, and it is not affecting all communities equally, including members of Black, Asian, and minority ethnic groups. The different programs and initiatives that take place within a community have strong potential to be a cost-effective way of having a positive effect on many of the things that protect and promote mental health and well-being. For example, through building the social connectedness of a community or helping to manage the stress associated with financial difficulties. In our study, we defined community interventions to include any non-clinical programs or activities. So by this, we did not include any drug therapies or clinical therapies such as cognitive behavioral therapy. And it had to have been taking place within the community or delivered by the community or voluntary sector. And for the purposes of this study, these interventions had to be seeking to support the mental health and well-being of minority ethnic groups in the UK. In this scoping review, we sought to answer the question, what is the evidence for community interventions that aim to improve the mental health and well-being of Black, Asian, and minority ethnic communities in the UK? In order to capture all relevant studies, we built our search strategy around 4 components. Ethnicity, which we define using the UK Office for National Statistics terms, which included mixed, Asian, Black, and other groups. Gypsy or Irish traveller groups were the only people that we included from the white category due to the documented social, economic, and health inequalities that they face. We were looking only at interventions for adults. Studies had to have taken place within the UK and had to include participants who were either well or had a common mental health condition. This means that we excluded interventions that were targeting those with severe mental illness or refugees and new migrants, because we know that this requires need for more tailored and specialist support. With this strategy, we searched 6 databases. We decided to exclude grey literature because we found a lot of small-scale community programs that did not have any publicly available data. Through this search strategy, we found 4,501 studies to screen, and of these, we included 7. Each of these were very different, and they included therapy sessions delivered by lay health workers, peer support groups, an educational leaflet, free gym access, and a family services program. They were all of varied study design. Only 3 reported a significant effect on mental health outcomes, and 6 out of the 7 were appraised of having a high risk of bias. Despite each of these interventions being so different, 4 key common characteristics did emerge. Firstly, most were aiming to address social isolation and loneliness through programs that aim to build on peer-to-peer support. This focus is in line with evidence which does suggest that people from minority ethnic backgrounds prefer to talk to people about their mental health within their social circles rather than to a professional. These interventions were also predominantly delivered by lay health workers who are of the same ethnicity or the same life experience and community as the participants. The outcomes from these studies suggest that there is something about this that may make mental health support more accessible and help reduce the associated stigma with accessing mental health services. The interventions also focused on, and some of the qualitative outcomes suggested, that it is highly valued when programs are culturally sensitive, such as providing female drivers to transport South Asian women to a social activity, or by delivering culturally adapted educational materials. Lastly, almost across the board, the interventions had a strong emphasis on signposting. That is, linking the people that are accessing their services to other services which exist within the same community. This has been widely adopted in England through social prescribing schemes, but to date there has been little done to ensure that these schemes are culturally appropriate. Ultimately, our scoping review has found that the evidence here is limited and weak methodologically. There is a clear disconnect between what is happening within communities and the published evidence. We need to be able to identify successful interventions so that they can be scaled and implemented elsewhere, but there are many barriers to doing this. Third sector organizations, who are predominantly providing these services, are often bound to deliver short-term projects and lack resources for robust evaluation. We need to jointly, including academics, policymakers, and the community, build this knowledge base and ensure that sufficient resources are being allocated. It is also clear from this review that although information is limited across the board, there are particular absences. For example, 4 out of our 7 studies were specifically targeting women, with none targeting men, and there was a strong focus on the South Asian community. But we need information for all people who are classified as minority ethnic, as well as we need to understand differences among groups. It's also critical that we consider intersectionalities, such as between gender and ethnicity. This calls into question the use of labels which are very common in mental health research, such as Asian or Black African, which contribute toward this idea that ethnic minority groups have the same mental health needs. And lastly, most of the studies focused on people with existing common mental health conditions, with very little done to tackle structural and institutional factors, as well as working to promote positive mental health. But it is important that these services are provided and that we better understand how they can be successfully implemented, because these are critical components of strong public mental health and sustainable health systems.